So again, I think thanks for participating and being energized. So now everyone's mind is alert and ready to start. And again, I think this session of the presentation is really around, again, contextualizing the clinical aspects of the treatment and the management of patients, and really giving you some of the dilemmas that happen as we manage children and adolescents living with HIV. So we've got an esteemed panel with us. So I'm going to, Nadia, you've met, and Ted, you've met. So I won't go into them. And then we have with them is Lisa Frigati, who's from the University of Stellenbosch in South Africa, and Alistair Bradford from the Great Ormond Street Hospital in the United Kingdom, who's really going to provide us with some insights in terms of the cases that we have. So we've got two cases presented, and firstly I'd like to thank our two presenters. So Vincent Ganu is from Ghana, and he'll present the first case, and we'll have some discussion around those cases as we go along. Thank you.
Okay, thank you very much. Good afternoon. And I bring greetings from Ghana. And I want to thank the organizers for giving us the opportunity to make this presentation. I think the 2 days have been very insightful, and especially today, many of the things that have been discussed here. In fact, you'll see the flashes of them in the presentation that I am about to do. And I want to take the opportunity also to say a big thank you again to everyone sitting here, especially for the last act that was done here when closing the gaps in the pediatric HIV care with the mother and the daughter. Will I say I shed a tear? Because this is what we see on a daily basis at the clinic. It's called emotional trauma. But when those of you sitting here, go through sleepless nights looking for solutions, for which we, the clinicians, can sit at the clinic and say, Mom, there is an injection. There's a better option. And the mom smiles, and just like how the little girl said, I like the injections better. I'm grateful to all of you for reducing our emotional and psychological trauma as clinicians. We always talk about psychosocial for the patients and the caregivers. But today, I want to say thank you to all of you on behalf of all clinicians, for reducing our emotional trauma. Thank you very much. So I'll start. Yes, so I have nothing to declare. For the outline today, I'll take you through a history. I'll take you through a clinical examination, a differential diagnosis, and then we look at investigations, management, clinical progress, and then a take-home message. So we are looking at a 17-year-old who presents with a chronic rash. So this is a 17-year-old female BA who is a 17-year-old male who is a student who presented with a skin rash for 4 months, has been known to be living with HIV, that's a vertical transmission, for 12 years, but then has a strong long-term history of issues with compliance on antiretroviral therapy. He self-reports that he was well until he developed the rash on both forearms. And then he presented to a nearby clinic. He said he was given some antifungal cream. However, the lesions persisted. And after a month, he realized that the lesions had spread to his trunk and then to his shoulders and then to some part of his neck. So he goes to another clinic. He didn't go back to the first clinic, he goes back to another clinic. And then he was given, from what he described, oral ketoconazole, so he could spell for you. But then the dosage, we couldn't tell whether he had the 200 milligram, 400 milligram, and then the duration too, we can't tell. The caregiver was always never around, so caregivers could not give us accurate information. So still, there was no improvement in the rash. So he resorted to self-medication, got some clotrimazole cream, which is over the counter in Ghana, went to get some herbal and alternative medicines. But when he did not see any improvement, and it was time for him to come to the adolescent clinic as he's been scheduled, then he presents himself, and that was after 4 months. On direct questioning, he had occasional itching, but the rashes were painless. He had some malaise, but aside that, no fever, no chills, no anorexia, no coughing, and he didn't have any pain on swallowing. And then, no significant weight loss. However, he reported topical steroid use when he was seeking alternative medicines. His systemic inquiry was unremarkable. He had been treated for disseminated TB for 12 months. He was treated at age 5. And then he had disclosure done at age 15. His treatment history, at the time we saw him, he was on Combivir efavirenz. And for the family history, there are no known history of chronic illness. For the social history, we have the dad, who is the caregiver. However, the mom is deceased, and the mom died when he was 2. And then he has an older sibling who is 27 years. However, it's important for us to note that aside our patient who is positive for HIV, the father is negative, the older sister is also negative. And from the history that we had, we thought the mother died from complications of HIV. So the disease impact, he had to stop school. He was in the senior secondary school, he was in the boarding house. He had to drop out due to the rash because of his colleagues laughing at him and asking questions. And then he avoided social gatherings. So here's our patient. And as you can see with the rash on his trunk, the back of, on his back, he is also extended all the way to his butt. And we could see that they are scaly rashes. They are annular. Most of them are annular. They are round, ring-like lesions. And some of them have some central clearing over there. And then we have their borders being raised. If you look at the one on the shoulder here, the borders also being raised. And then we also have the post-inflammatory hyperpigmentation. The pictures down there is just to show you what it looks like in the lighter skin. But the top one is for the patients that we saw. On further clinical examination, there was nothing of note in most of his examination findings. What I would say is that the last viral load that was documented was 8 months prior to presentation, and that was 22,000 copies per mil. And the last documented CD4 was 2 years prior to presentation, which was 576 cells per millimeter cube. So at this point, I'll pause and ask, what do we think is happening to this adolescent, and how do you want to manage? Thank you.
So, Nadia, you're going to start.
Yeah. So for cases like this, I just wanted to note that the history and physical often is not one-off. Many times you have to go back, get more history, and sometimes the whole picture comes in little drips and things for you to understand what's going on. But in terms of evaluating a rash, some of the points you raised, is it raised, is it itchy, is it pain, is it swelling, and what is the chronicity of it? And in managing this in Ghana, in a family that, has HIV particularly, you have to also consider what the family may have in terms of resources. Because one, are certain diagnostics available? And two, can they afford the diagnostics? In US, for instance, if you are confused about things, you could send for a biopsy. Is there biopsy, and can they pay for it? So for me, in managing this adolescent, I would try to get more history, but at the same time, you have some information where you can say, okay, is this thing a rare diagnosis, or is this a presentation of something that might be common but looks impressive because you have a patient who has reduced immune system. So I'll stop there. Yeah.
So maybe so I'll hand over to maybe Ted. Do you want to take over from if this kid presented into your clinic in San Francisco? How would you manage him differently? I mean, it's difficult when you don't have access to diagnostic testing, but when you have everything available.
Since we have it,
Yeah.
I manage it. Right. So I mean, I think I agree, of course, with everything Nadia said. I mean, I think some basic evaluation would include, I'm interested to know the CD4 count. I mean, it was 2 years ago. We would consider this relatively immune intact if that were the count now, but certainly plenty of time for the CD4 count to decline. I have to say I'm a little bit, in thinking of how I would evaluate, I'm a little bit biased by the second pictures as much as I am the first. I think the first look much more dramatic and a little more mysterious. I think the dissemination of it and the hyperpigmentation present a more mixed picture than the photos that you showed below, where it's kind of very clearly,
Sorry.
where you have you describe in the history, and you show in the pictures kind of the annular, the kind of ring-like formation with the scale and the raised bumps and the central clearing, and that begins to speak to me pretty strongly of like a dermatophyte, a fungal skin infection. And so I think you look back then to the keep going. You look back then to the history that might have been, we'll see. I think I'll just keep talking. Was treated for a fungal skin infection. So that might lead one to think, oh, well, we've tried that and we failed. But I think oftentimes if treatment is incomplete, and as they described, they were having troubles with, we don't know how adherent they were. And of course, with an impaired immune system and really significant disease, oftentimes topical treatments aren't enough. So I think that's where my thinking would go. I would certainly get scrapings to look for fungus would be my first kind of diagnostic test in a CD4 count, I think. But we would, honestly, to be honest, Nadia, if this patient came into our clinic, it'd be pretty quick to get a derm consult and a biopsy.
Call a friend.
Just to admit that.
The other thing I was and this reminds me of a patient that I had, who had really extensive skin lesions that we tried to treat, but we were trying to treat the HIV as well. And despite the fact that we were trying to treat the infections, the skin infections were the most important thing for this patient. And no matter how much we tried to say how important it was to get control of the HIV infection, the skin infection was actually more important to this patient. And we could never get this patient to actually understand that you needed to take your ARV medication in order to control the skin infection. And so, I mean, Lisa, do you want to make a comment in terms of how do you navigate that? I mean, this is almost like a chicken and egg kind of situation. You need to get control of biological control in order to get dermatological control.
Really interesting that you said he'd actually stopped going to school, because that's obviously also letting you know how important the rash is to him. So it's a difficult one. I think I sometimes tell the parents of some of my patients that I can see when they've gone off their ARVs because their skin, so I think many patients and many individuals do relate skin changes to ARV adherence themselves without even realizing it. But I think, obviously the big thing here is actually control of his HIV. So I would sit with him, I would, if you have counselors at your clinic or, and I think it's probably important to get his father in as well, because it sounds like because there's no one else living with HIV in the household, maybe the family doesn't know how to approach it. It's not clear. I don't know if you said if he has disclosed to anyone at home or issues around that. Yeah, so that's what I would do.
Yeah, and again, I think sometimes the thing is really, I think, making sure that you understand what the priority in terms of your treatment paradigm is, and your priority for treatment may be different from what the patient feels. And that understanding that his priority may actually be not that viral load, it may actually be controlling the skin rash, and that that we are seeing it as a major priority, and we're working towards improving it. But you want to take over? Yeah.
Okay.
Can I add something real quick?
Yeah.
I would say in managing this as well, he was just disclosed to 2 years prior, right, at 15. You have to understand whether there's an element probably of depression that had him go off his meds and then, things sort of deteriorating to the point that he's having extensive infections and things like that. So part of the management, acutely, of course, the rash, but also providing some support for him as he sort of tries to get out of this situation. Yeah, thank you.
Okay. Thank you very much. Hello. Yeah, thank you very much. So I would just continue, and then maybe if there are further questions to answer, we'll do so. So we made a diagnosis of tinea corporis, and then we tried to also query an eczema, that's atopic dermatitis, and also sort of psoriasis, and also added whether this patient has failed treatment. And so we asked for the skin scrapings, for the potassium hydroxide, and we also asked for some blood tests, and then we added the viral load, and then the HIV resistance testing, unfortunately, is unavailable in Ghana. And then for the management, because he has received other forms of antifungals in the past, we gave oral grisofulvin, 500 milligram daily for 6 weeks. And then we gave him something for his itching, which is the Piriton. And then we referred him to see the dermatologist. And here in the clinic, usually when you refer anyone, now they say Ghana has gone digital. So you refer in the system. When he goes to the dermatology clinic, he's going to be billed and paid and then booked. And so what we do for our patients is that we call the dermatologist. We speak to the dermatologist. So we have a good relation with most of the specialists. And then we tell them that, okay, someone is going to come. And once we write a referral, we write the name of the dermatologist on it. And so the dermatologist gives time. Sometimes he says, come to see me in my office personally, don't go to the clinic, or else they will bill you. So that's how we sort them out. So we asked him to go for review in 2 weeks. Clinical progress. He defaulted the review date. He did not come. He was not seen. The phone numbers in the book, when you call, the father says he's busy. He will come when he's free. And so we saw him after 3 months. He did not go to see the dermatologist. His father says there are lack of funds. And the lesions had worsened, despite completion of the 6 weeks of grisofulvin. And again, we queried compliance, because father cannot tell us that I actually stood there and saw him take. Father says I leave for work as early as 4 a.m., and I come back at 8 p.m. And so I asked him to take the medicine. When he asked the boy, he's also not too sure whether he's taking it for 6 weeks. So we're not sure of the compliance. And father admitted to application of herbal ointments, and we're not too sure whether that contains steroids as well. However, for the lab tests that were done, the key things were that the CD4, so for the CD4, we also do not have access to CD4 in Ghana. And so we currently pay for it. It's almost, I think, $50 or $60. So we, the clinicians, paid for this. And then it showed that his CD4 was 45 cells per millimeter cube, down from the 576. And then the viral load had gone to 151,341. And the skin scrapings too, he couldn't do it. Now, that's him when he came 3 months after. And so just for you to see this, I will go back to show this when we first saw him. And then when he came back after 3 months. So here you realize that now the lesions have extended. I mean, the whole back, now it's gone to the head, the face. In fact, when he came to see us after 3 months, he was actually wearing a hoodie. The only thing you see is his eyes. He did not want anyone to see him, and everybody was asking them questions on the way. What exactly was the problem? So his lower limbs everywhere were involved. At this point, what do I do?
It's a really tough situation, isn't it? That you've got a child that's clearly not adhering to their medication and is getting a worsening, very disfiguring skin condition, and we're not sure what's going on. So it's a very stressful situation for the family, for the young person, and also for the clinicians, because we don't know what's going on. And we've tried some antifungals. They didn't work. So does that mean it's something else? Are we missing a different diagnosis? So I think anyone in the room that saw this young person would be starting to get worried about what to do next. And I think, yeah, I mean, you know now that he's non-adherent, he's got a very low CD4, high viral load. He may have resistance to the regimen he's on. So we need to think about optimizing his HIV treatment, because it probably is HIV related, isn't it? No matter what the diagnosis is in the end. So if we get the HIV sorted, that will hopefully help with whatever's going on. And then I think you've just got to go back to your sort of basic medical training, thinking about all the differentials in a really systematic way. Is it infection, fungal, bacterial, viral, sexually transmitted infection, syphilis or something like that, manifesting in a strange way? And then the non-infectious things like drug reactions, inflammation, even a malignancy or something like that, or a nutritional deficiency are all going through my head. I think it's probably HIV related. And I've seen the case before, so I've got the top of my list is probably still fungal. But yeah, I'd be thinking about all those other things, and it could be more than one thing as well. So a tough case, but I think I'd be really focusing on his adherence, psychosocial support, because that's not going to, adherence isn't going to happen without that. Get his HIV under control, and hopefully this will melt away, and we'll have time to think of other things to test, well, not test for, but maybe empirically treat.
Okay, thank you very much. So I'll continue. So we made a diagnosis of what is called tinea incognito, which is a fungal skin infection, which starts as the tinea corporis, and then later the appearance, the whole appearance of the lesion is altered because of the use of systemic corticosteroids, where in the history he said he had used some. However, what we also need to know is that in situations of severe immunosuppression, and here we've seen his CD4 has gone down all the way to 45. Yes, you can have the skin lesion appearing in that manner. And so this condition, the other thing also to note is that it's often mistaken for other skin conditions like eczema and psoriasis. And the treatment for those two, mostly you have steroids being part of the treatment. However, when you apply steroids to this lesion, the lesion just worsens, like how we've seen it. And that's what actually gives it that it's not eczema, nor is it psoriasis. And then we also queried our treatment, we also made a diagnosis of an HIV treatment failure based on the result. So we actually held his hand because the boy literally was crying. He's not going home if we don't sort out his skin lesion for him. So we had to pause, hold his hand, go all the way to meet the professor at the dermatology clinic. And we had a discussion. We call it a multi-unit discussion. And then we decided to put him on oral itraconazole, 200 milligram daily for 12 weeks. Usually the guideline says 4 weeks. We did 12 weeks, and then Whitfield ointment, where he will apply twice a day after bathing. And we actually, just for compliance purposes, we told him that he should use it as his pomade. So when he finishes bathing, he uses the Whitfield ointment. He doesn't apply pomade. And then we gave him the ketoconazole shampoo, 1% for hair application daily for 7 days, and then twice a week for 3 weeks. And then we had the ARVs changed to the tenofovir, lamivudine, dolutegravir. And patient was counseled. I must say that the father was a key person here when we were doing the counseling. There were many issues which we had to resolve. So most of these things we had to purchase for the dad, because if we don't do that, we think they'll come back and things will be worse. So we had to sort that one out. And then weekly visits were organized because, you know, itraconazole for 12 weeks, we needed to monitor for hepatotoxicity. And so we needed to see them on a weekly basis to see. That's him 6 weeks when he came. And you can see his head, that the hair, yes, the hair is gone, but the lesions are clearing. 6 weeks, but the lesions, you can still see, they were there. You can still see the outline. So we continued for 12 weeks. And then 12 weeks, as you can see, the back totally cleared. The hair has come back nicely. And this is before and after. And that's him now. He's happily in school now. He's telling me that he wants to be first in class. This time I said he should push hard and do that. And then his CD4. Currently, we've been supplied some CD4 qualitative tests. When we applied to him, it was greater than 200 cells, and his viral load is target not detected. Our take-home message: common things may not be common in HIV patients. And depending on their immune levels, the things may appear atypical. And therefore, you need a high index of suspicion and actually a good clinical acumen. Your history and your clinical examination are very, very important for you to be able to make a diagnosis and then start some empirical treatment in our resource-limited setting. And for tinea incognito, usually requires systemic antifungal. I must say that the duration of treatment is usually adjusted based on the clinical response. So though the guideline says 2 to 4 weeks, the dermatologist made us understand, and this is a very old dermatologist. In fact, the younger ones were saying we shouldn't have gone beyond 4 weeks, but the older one said, I have seen this before, and we are going to go 3 months of it. And for our place, this is what we do. For every skin infection, you treat. When you see everything disappears, you do an additional 2 weeks of treatment just to make sure that you've cleared the infection in the system. At this point, I want to say thank you very much to the organizers for inviting me once again, and thank you too for listening.
Again, yeah, so I think again, thank you to the team. I think we don't have to move to the next case, but again, really, positive outcome, and again, I think it speaks to the need to look at, common things happens commonly, but in especially immunocompromised patients, that the presentation may be completely unexpected, and especially when you have multiple, steroid use, topical herbal use, that may impact the treatment. So, yeah.
One quick thing. Note that things that are herbal or herbal ointments or things that they take are not necessarily purely herbal. A lot of the herbal people, you will see aspirin, penicillin, and things in these medications. So we are not ruling out that some of the topical herbal things you use actually may have had steroids in them. So they do mix them with modern medicine sometimes and can befuddle the picture. So please note that.
Great, thanks a lot. So we're off to the next case, and again, I want to introduce Kagiso Mochankana. He is a newly minted pediatric infectious disease specialist. He was trained at our unit, and he is now back in Botswana to join the infectious disease community in that country. So he's going to present a case of an unusual cause of airway obstruction. Kagiso?
Greetings to everyone, and thank you, Prof, for the invitation and the constant mentorship. I think for the sake of time, I'll just try to be a little bit quick. So as you pointed out, we'll be presenting a case of an unusual cause of airway obstruction in a child, and is one of the complicated cases that we've seen in our clinical practice. Sorry about that. So I have no disclosures, and the outline is almost the same as the previous presenter. So the case of a 5-year-old child who is a male who was living with HIV and had defaulted ART due to poor social circumstances, and we'll see the social circumstances that this child was living in. And he presented to our hospital in South Africa, Durban, with persistent productive cough, which was of more than 2 weeks duration, and had significant weight loss, in which, as we evaluated him, he was actually quite malnourished and had persistent fevers prior to presentation for a time period of about 7 days, with progressive malaise and fatigue. And at the point of presentation, the child was actually quite distressed in terms of the respiratory system, as he was having a typical mild inspiratory stridor during his assessment. And with regard to his HIV status, as I pointed out, he was diagnosed with HIV in childhood. And unfortunately, due to the paper-based system in the hospital, we could not find any records of this child in terms of when he was initiated on treatment. But what we could find in the online lab system, we could find that in December 2024, he had a viral load that was 105 copies per mil. And of note, after that, this child developed defaulted ART. And at the time of admission, this child was not on ART, and we could not really know for how long this child had defaulted his treatment. His vaccination status was unknown at this point because we didn't have the under 5 card for this child to be able to see which vaccines he had received and those he has missed. And with regards to his nutritional status, as I've pointed out, that he was quite, had significantly lost weight. In terms of the anthropometry and plotting, he had severe acute malnutrition based on the WHO chart in terms of the Z-scores. And with the social circumstances, as I've pointed out, that this child had quite a complicated social history. He initially was living with the mother, who was living in a different part of the country, which was in the Eastern Cape. And later on, he was taken in custody by the father, who was unemployed and was living in an informal settlement. And the overall household income was actually quite low, with less than 2,000 rands per month. And in South Africa, it's quite difficult to be able to survive and provide basic amenities with less than 2,000 rands per month. And hence, the social services tends to offer support. And this child was offered a grant to be able to augment the income that the father has on a monthly basis. So in the initial physical examination of this child, the pertinent findings was that it was quite significantly wasted, and evidence also by the anthropometry, as I've stated in the previous slide, and had prominent generalized lymphadenopathy, especially around the cervical region. He had some parotid enlargement, and with digital clubbing was also noted. As I pointed out, that this child, in terms of history, he started towards the point of admission, was showing some signs of distress and abnormal breathing. On his respiratory examination, we noted quite significant tachypnea with stridor, and also there were some diffuse coarse crackles and some wheezes also noted, which shows that this child had quite an extensive lung disease at the point of admission. And the abdomen had some hepatomegaly, not too much significant, but just about 4 centimeters below the costal margin with no splenomegaly. And then the CVS and CNS system were basically unremarkable. So if you can look quite closely, this is an X-ray of the child, the AP and lateral film. And we can see that the obvious thing is that the child has enlarged mediastinum with possible mediastinal lymphadenopathy. I'm not sure if it's visible there, but you can see that there's some bit of airway obliteration, especially on the right and left main bronchi. And when you look at the interstitium, there's more of like fine interstitial infiltrates, which could some be possibly a miliary pattern on the chest. And then if you look at the lateral, there's obvious perihilar lymphadenopathy with the donor sign, inflamed fissures. There was slight increment in terms of the AP diameter, which could possibly mean that there was airway trapping to some extent. And these were the initial investigations of this child on arrival, and I had tried to highlight those that are quite pertinent to a threat, with the HB was low at 7.9, translating to a microcytic anemia. The UNE were unremarkable. LFTs, he had hypoalbuminemia at 21, and then the inflammatory markers, he had an elevated CRP of 164, and his CD4 and viral load at point of contact, he had a CD4 of 495 with a percentage of 47.6 and a viral load of 41,000, which translated to a log of 4.61. His CSF was basically unremarkable, and the culture did not have any growth at 48 hours. So with that broad history, I think what do we think the differential diagnoses are for this child?
So, Lisa, do you want to?
So I think, again, there's two things here. The one is whatever he's presenting with now, and then he's also failing his ART, it seems. So I think on my list of differential would be, coming from South Africa, tuberculosis, number 1, 2, and 3. I would also then think of LIP, although we seldom see it anymore. And I think the children that I've seen with LIP tend to be lymphoid interstitial pneumonitis. They seem to be more well, and this child is obviously quite ill. Then I think also in the context of South Africa and perhaps many other countries where we work, we'd have, and knowing that we can't check his immunizations, we'd also have to think of diphtheria. Very sadly, actually recently, we lost one of the initial SURE trial patients, and she died of diphtheria in the adult ward. So I think that's something we should always remember. And then, of course, he could have chronic lung disease. He's clubbed. And he could have now just an intercurrent viral or bacterial infection. So I think I'll stop there.
Hand over to maybe Ted, you want to take the next?
Sure. I mean, I think, of course, I agree with that differential. And this is definitely one where I'd want to consider the possibility of more than one diagnosis. I mean, I think the clubbing certainly points to a chronic process, but the more recent history could be a superimposed viral kind of croup-like presentation, which could be caused by any number of viruses. Something like RSV can cause like interstitial lung findings with also croup, so you can try to pull that together. I think were this child more immune compromised, the differential would get larger, and it's consoling that the CD4 count's a little bit higher. But I'd worry. I mean, the kind of cause of the upper airway obstruction could be broader. It could be Kaposi's, could be retropharyngeal abscess. I think you really would want to see how that evolves. I mean, that's one of those things I think to hear it, you'd want to see and how significant the airway compromise was to evaluate. But I'd be concerned about that. Pneumocystis, again, where the CD4 count lower. And I think TB, honestly, again, with this combination of how chronic it is, the malnourished state, the lymphadenopathy, the clubbing, I mean, all that, it kind of keeps that high on my list.
Okay. Thanks. So, Kagiso, you Karen? Yep.
I think that's exactly what we thought about in this case, based on its complexity and also the issues surrounding that. But the two main ones that we thought could be highly likely in this case is TB and LIP. But I think there's been more explanation on the LIP, why less likely based on other features. But TB also, based on the incidence in South Africa, was one of the top differential diagnoses that we considered in this case. And I think a lot of things tied up to that also, which meant that we looked further for it and did further investigations for this case in order to confirm our diagnosis. And we did a TB nut on the sputum, which came back positive. And it's actually, with pediatric care, we know that most of our samples are negative. So this was a good one for us to be able to clinch that diagnosis, to have a positive test, in which in South Africa we use the BD-Max, in which it's able to tell us the rifampicin sensitivities and also INH sensitivities. And in this patient showed rifampicin sensitivity, and I think INH was also quite sensitive. The CSF was negative, and we furtherly did a CT brain on this child based on the fact that there's possibility of disseminated disease, and also with dissemination there's also high risk of CNS disease, in which the pertinent thing that was only noted on the CT was that there was some areas of demyelination or ischemia, and the overall assessment was that there could be possibility of an inflammatory. The inflammatory and infective lesions were less likely in this case. And tying up together with the CSF results that we had shown in the previous slides, it meant that this child did not have any CNS dissemination. His further imaging, in which we did, was an abdominal ultrasound just to look at if there's any intra-abdominal involvement, was negative. There was no evidence of intra-abdominal lymphadenopathy or any splenic granulomas or hepatic lesions in this patient.
Before we go to the next one, okay, go through this one first.
Yeah, so I think I'll just be quick on this one. So we looked at a broad differential diagnosis of this patient based on the clinical presentation, in which we look at the three main factors. It says, is it an intrinsic etiology, an extrinsic etiology, or a mixed picture? And in this child, when you look at the different differentials, you see that there's a mixed match of infectious and non-infectious etiologies. And our thought, mostly based on this case, we thought there could have been an extrinsic factor in terms of compression, and tying up also with the radiological features that we noted from the chest X-ray. I think in view of time, I'll just say that, not go through each of the differentials here.
So maybe just to ask, so this is the one question. So I think it certainly looks like there's TB here. The question would be, so would you empirically start steroids in a patient with a CD4 count of 400 and something with TB before you start? So this child is currently not on antiretroviral treatment. You're probably going to have to start them on treatment. Should we start empirical steroid therapy to prevent an iris phenomenon?
I think, if I can, in this case, yes, because he's symptomatic, I think, from his lymph nodes. So his stridor is most likely from the lymphadenopathy. And I think, for example, if he had TBM and a low CD4 count, you would start steroids in any case. So personally, I would.
Alistair, do you know?
Yeah, I totally agree. I think I would go, I always, as a guideline fan, I would go to different guidelines and see what they say in different settings about what to do. But I think most of them would say that in this scenario where you've got evidence radiologically of lower airway compromise and clinical signs of upper airway compromise, you're starting TB treatment, and just, even though he's got a good CD4, he's a sitting duck for iris and critical airway compromise. So I think the risk-benefit would favour giving steroids.
And I'll build on what Alistair just said insofar as you go to the guidelines, and the guidelines might not be so clear on this, right? Like, it doesn't kind of meet criteria in terms of it's not automatic as with meningitis, but I think it's the moment for the clinician, right, to say, but it just makes sense, right? I mean, you have, and particularly with the airway compromise, I think that you get to the kind of the rationale for it, and when I think you need to be a doctor and not just follow guidelines.
Yeah.
My approach is just ABC in this patient, and with the stridor, that makes me uncomfortable. So that's the immediate threat to his life is the respiratory issues. I would start steroids.
Yeah. So I think, again, sometimes our guidelines are quite opaque around certain areas, especially, I think for a low CD4 count with starting TB treatment, you'd consider empirical steroid therapy. Certainly, I think there's a lot of red flags in this kid that would warrant you starting empirical TB treatment, steroid treatment with the TB medication.
Maybe I can just add, I would also cover with antibiotics in this setting. I think he's got a high CRP. I wouldn't want to just give steroids and TB treatment alone.
And also all of this on admission, please, in the hospital.
I think I'm interested in the case and your thoughts around this. So, I mean, I think there's one of these cases where you don't want to unnecessarily go look at the airway of stridulous children that are on the brink of respiratory failure. On the other hand, I really want to see what's there in this case, right? So I think you have to figure out when in your management, I certainly would I'd start treatment, I'd start steroids and see how things go, but that would be a clinical management challenge, I think, as well.
And I think one of the dilemmas for us is really around, is this a Hodgkin's lymphoma? Especially because he had quite extensive cervical lymphadenopathy, and so we actually waited until we had the positive TB NAT before we were feeling comfortable enough to actually start steroids. And so again, you do need to, because once you've started steroids, that may impact your ability to make the diagnosis, and really our hematologists start getting angsty with us and throwing their toys out of the cot.
And just quickly more, I did write down Hodgkin's lymphoma question mark. Yeah, I've seen a patient like that, but I looked at all the cell lines, and it was really only one, I think. Maybe I'm confusing, but there were certain things that moved me away from that. But there have been cases like this, and just you have to think about that too.
So we're going to take one more comment. Alistair, you need.
Well, I was going to ask you the question, or anyone. So I was just going back to that the CT head report. I just found that slightly confusing about how you can definitively say something that's got abnormalities on it is not TB. Yeah. So I think in my centre we'd be debating about whether to do an LP or not. I don't know.
So he had an LP and it was a normal.
There was an LP. Oh, sorry, I missed that.
And his NAT on the CSF was negative.
And protein and cells. Okay, fine.
Kagiso, do you want to carry on?
Yes, thank you. Thank you very much. Very nice discussion, because that's exactly how we thought about this case and trying to fish in the possible differential diagnosis in this patient. So with the management plan of this patient, we diagnosed him as a severe tuberculosis with HIV co-infection. And I mean, the tuberculosis was confirmed on all grounds in terms of clinical, microbiological, and radiological assessment, which is not a common thing for us as pediatricians to be able to appreciate, because the microbiological confirmation is actually usually negative in most of our patients. And also there was complication of suspected extrinsic airway compression with upper airway obstruction, in which the differentials are stated TB, lymphoma, and all the other were entertained in this case. And our initial plan was that to start the patient on 4-drug TB regimen, and we know that in South Africa, usually for disseminated TB, we use ethanolamide, but this was at a time period when ethanolamide was not available, but we ended up using ethambutol. But On a positive was that this patient did not have CNS disease, which I don't think was much of an issue in this patient. And we started steroids because of the possibility or because of the upper airway obstruction. So the patient tolerated treatment for a time period of about a week, and we were quite comfortable with initiating ART in this patient, in which we started him on ABC3-TCD-TG. And we referred him for nutritional rehabilitation because we could note that this child was severely malnourished. And as part of the initial treatment for this patient, we treated him as a case of severe pneumonia with empiric antibiotic therapy as per the guidelines in South Africa. And because of the complexities in terms of the social circumstances, we started engaging the social worker so that even after discharge, those issues could be ironed out and we ensure good compliance of this patient post-delivery, post-discharge. And with the clinical progress, I've noted that this child during the first week did quite well. Even the nutritional state with the rehabilitation, things quite well. He moved from being severely malnourished to being closer to normal in terms of his weight, with stabilization of the social circumstances by the social worker. And we could appreciate the effective absorption of the TB medication and also with good tolerance of this patient. We didn't have any complications at this time of treatment for this child. On the second week of treatment, towards the end, we started weaning down the steroid, as we started quite high at 2 milligram per kg per day, and we weaned him down. And on the third week, we started noticing that the stridor that was initially getting better, it now started again once we started weaning the steroid therapy of this child. And the stridor was graded about grade 3. And with our institution, initially patients are admitted in acute ward, and when they get better, they get downscaled to the ward where they will continue their medication. And unfortunately, because of this deterioration of this patient, we had to move the patient back to an acute ward due to the worsening of the signs and symptoms and possibility of requiring intubation because the stridor was actually quite bad. We know that with grade 3, it means that both in inspiration and expiration and possibility of complete airway obstruction in this patient. So I think we've partially addressed this part, but I think is one area also to further discuss in terms of what could be the possible reasons why this child has worsening stridor.
So I think we run out of time, so let's just move on and then maybe we can have a discussion at the end.
Okay, perfect. So we involved ENT as part of management because they basically manage the upper airway of patients, and they did a laryngoscopy in this patient. Unfortunately, the video can't play, but what they noted is that they saw quite swollen vocal cords with red beefy appearance and some granulomas around the upper airway of this patient, and they thought that this could be most likely TB larynx. And in view that this patient started worsening after we tapered the steroids, we thought this could be a TB larynx iris. So we switched this patient to more potent steroids, in which we gave him a course of dexamethasone for 2 weeks. And once the patient got better, we later on transitioned to oral prednisone, which he tolerated the weaning at this point in time and with progressively improving clinical state. So we continued his ART and the Cotrim prophylaxis and successfully stopped the steroids prior to discharge, which was within 8 weeks of admission without any further iris. And this was him now walking out of the hospital, coming in with severe distress and walking out happy and free on his ART TB treatment and also on Bactrim prophylaxis. But then this wasn't the end of the story for him. A month later, on his scheduled review, we got a call that this child has developed significant increment in the cervical lymphadenopathy, which is quite painless. And in some areas, especially on the other side, on the left side, there was some draining sinuses. So we entertained again, this could be iris. So we reinitiated him on prednisone as an outpatient. So he's still on treatment and will furtherly be followed up just to see how he responds to his therapy. But in view of that and the complexity of the case, I think the take-home message on such cases is that we should be able to maintain a high index of suspicion for typical tuberculosis presentations in children and HIV, as we saw that in this child, he had laryngeal involvement. And we need a proper multidisciplinary, collaborative, and comprehensive management, because we find that with the children, when they come to us, it's not just only one disease entity. The social aspect has an implication, the economic aspect has implications, and also the disease process. So we should manage the patient holistically in order to have better outcomes at the end. And we should be quite vigilant in monitoring and prompt intervention for TB iris. So in this regard, we should have like at least shorter reviews for this patient post-discharge so that we catch these cases as early as possible before they get to the worst state and possible mortality. So we should be quite vigilant in managing such cases. Thank you.
So thanks, Kagiso. Again, I think we ran out of time as usual, but I think again the one question that maybe just someone wants to just maybe speak about is really around how long do you continue steroids for? Do you continue steroids for the entire duration of TB treatment? That was really the dilemma we had, is to really how long do we just continue in this child, and we eventually kept him on low dose steroids. We weaned it down to the lowest level, and then we just kept him on steroids for, he's now on 3 months of TB treatment with steroids. If anyone wants to make one last comment, and then we can hand it over to Elaine and Lynn.
I was just wondering about contact tracing, who was the index case, and although he's a child and we wouldn't usually think they would transmit TB, but with laryngeal TB in a coughing child, I think there would be a risk. So. Yeah, so I was wondering if you comment on that.
Yeah, so I think we do think that because he was transferred from the maternal family to and usually the transfer happens when the child gets sick. So I think he had his TB, when he was living with the maternal family, and they, brought him across here. So I think we screened everyone else in the family. We couldn't find any direct cases of TB within this family in our setting, but certainly I think in the home setting there was likely to be TB. So with that, I'd like to really thank our panelists and then our two presenters, so Kagiso in Botswana and Vincent, who's joined us from Ghana. So thank you very much.